Good morning and welcome to another episode of Ask Dr. Murphy. I hope everyone is doing very well today. My name is Katie Berg and I'm a research study coordinator with the Havey Institute. I'll be leading today's discussion. I'd like to welcome and introduce Dr. Robert Murphy. Dr. Murphy, how are you this morning?
Good morning, Katie. Thank you.
Dr. Robert Murphy is the Executive Director of the Havey Institute for Global Health and the John Philip Fair Professor of Infectious Diseases here at Northwestern's Feinberg School of Medicine. He answers your COVID, public health, and infectious disease questions each week on the Havey Institute for Global Health's Facebook page. Today, Dr. Murphy will be answering viewer-submitted questions and reacting to the latest COVID headlines through today, May 18th. We invite you to submit your questions via Facebook at NU Institute for Global Health or by emailing globalhealthinstitute@northwestern.edu. I'm going to start with some updated COVID statistics for the United States. As we reported last week, however, laboratories in the US are no longer required to report COVID case by number. So just the average for the new cases per day is an estimate. That estimated number of new cases per day is 10,305. We are averaging 4,073 new hospitalizations per day and 100 COVID deaths per day on average. Our new booster proportion has stayed steady at 17%. Dr. Murphy, what are your reactions to those numbers?
Well, the reporting is going to basically be very limited now. We're going to get death rates and we're going to get hospitalization rates and pretty much nothing else because the laboratories no longer have to report it. As of May 11th, it's basically all over for the reporting. The emergency is over and we're in the endemic phase. So we were expecting this, and this is great news. We're down at about the level of flu as far as deaths per day. Now remember, COVID is more lethal than flu, and that it outcompetes flu. But anyway, we're in the same endemic state as influenza is, except that COVID can happen at any time of the year. So all that's good. It's still around. You can still get diagnosed. You can buy over-the-counter tests. You can get Paxlovid, the drug that's also out now on the market, free. Not free. Freely on the market, but you have to pay. Many insurers do pay, and public aid pays, and various funders of healthcare in the United States do pay. So all that stuff will continue, but it's just going to be at a lower level.
Absolutely. And starting with some very important COVID news, there was a recent article published about the epidemiology of long COVID disease in United States adults. Could you give us a little background on long COVID and let us know some of the most important findings from that study?
Yeah, this is a study reported in Clinical Infectious Diseases, very respected journal. And they followed over 3,000 US adults, 18 years of age and over. And their number, interesting for people with symptoms more than a month, and some of these up to 12 months or longer, was 7.3% of people have long COVID. So that's a number we've been throwing around out there already. So this just confirms that long COVID is, when you really look at it closely, like epidemiologists do, it's about 7% of people will have long COVID. The interesting thing is the risk factors. So women are more at risk. Younger people are more at risk. In other words, it's not on the elderly so much. It's women, people with underlying diseases already, they have more symptoms. And non-vaccinated people are more likely to get long COVID. So, those risk factors also were known in the past, but this is just a nice confirmatory study that, just confirms what we already know with some harder data here. And so it's not overwhelming, but it is 7%, which is a very large number, seeing how almost everybody had COVID. And it translates to millions of people that are symptomatic. Now, with the emergency ending, it's going to be interesting to see how this is handled by the insurers and the payers in the country. It is affecting younger people who are in the working pool And so that is going to have a big economic impact on the economy at large, and plus, of course, for the individual. But the good news is that most people do get better over time. That it doesn't tend to like get worse with time or stay flat. It does go down. So hang in there, get some medical treatment by a good doctor, and hopefully it will go away.
Absolutely. And I saw another interesting fact that the United States seemed to have a higher prevalence of long COVID than other countries or places, for instance, the United Kingdom. Do you have any thoughts on why that could be?
Well, no, I don't know why. That really needs to be studied. However, the United States, of the high-income countries, our peer countries, is the lowest vaccinated, lowest boosted. So that could be part of it, because we know unvaccinated people have a higher rate of long COVID. So it might be related to that, but I really, I'm just thinking off the top of my head. That is not based on any data. There's a way to adjust those numbers for that, but right now we don't really know.
An area for more research. It's very interesting.
And further study, as we say in the scientific literature.
Absolutely. And speaking of the vaccines, there is news that the United States is no longer offering the Johnson & Johnson vaccine. Can you tell us why that is?
Well, first of all, the whole vaccine uptake is really low. We never got over 17% for the new bivalent vaccine, which is really sad because the bivalent vaccine works much better. But we're still going down in the numbers, as you see. Now, the J&J vaccine ran into some trouble because of side effects. They were rare, but there were advantages to the vaccine, very inexpensive to make. And it was approved as a single dose. So there were some big advantages. And worldwide, over 2 billion people have taken the Johnson & Johnson vaccine. I mean, incredible. It is a much easier technology to manufacture, much more so than these mRNA vaccines, the Pfizer and Moderna vaccines. But because of these rare side effects, the uptake really slowed down, and no longer available here because really there's not a market for it. And they're throwing away over 1 million doses that are expired because they didn't go. Now, throwing away expired vaccine doses happens all the time. I mean, this is not unusual at all. The cost of those goods is actually not that much. So they have Johnson & Johnson, worldwide had a they offered a product that was inexpensive, easier to store. You don't have to have that super cold chain thing. And so there were many positive things about it, but it just never took off here.
Mm-hmm. That's interesting. And moving on to another very interesting but unfortunate story, there was a news article and a paper published that showed that people with pre-existing dementia showed rapid progression of their condition following COVID-19. Can you tell us a little bit about this study?
Yeah, it's a very small study. It's only 14 patients, but it was a nicely done study, people with different kinds of dementia. And they did worse when they got COVID. Now, this should be no surprise to anybody because we know everybody with underlying diseases does worse with COVID. I mean, so this is nothing really unusual. The good part of this study is that, however they were looking at it, it didn't look like COVID caused dementia. I mean, it's not related to the cause, but if you have it, it makes it worse. So it's a little study, but it does confirm again. We shouldn't really be surprised with these results, but they're refreshing in a way that there's no cause associated with having COVID.
Absolutely. And moving on to some more global and infectious disease related articles, there was a potential risk for new Mpox, formerly monkeypox cases here in the United States. We are not going up per se or peaking, but what can you tell us about these new cases?
Well, it kind of was dwindling down. A lot of people got vaccinated, behavior changed, but all of a sudden there's an uptick, including in our own clinics at Northwestern. And so far, in the reports I'm reading, nobody got hospitalized. Some people were very sick, but the weird thing was most of the patients were vaccinated. So we don't know the efficacy of the vaccine because we don't really know the denominator. But just in the cases that are showing up at our doorstep, most of them are vaccinated. So this is we're kind of back to square one. It's not that the vaccine doesn't work, but even if you've been vaccinated, you could be getting Mpox. So we need to be vigilant. Now people have to, when they see any kind of rash or anything unusual in a sexually transmitted infection situation, monkeypox goes back up on the differential diagnosis list, and we have to really think that maybe this could be monkeypox. Remember, there's treatment for monkeypox and there's vaccines for monkeypox. So only 23% of the people that are at risk have taken the vaccine, or they're fully vaccinated. So back to square one with Mpox.
Man, that's not great news, but
No.
I'm very glad to hear that there's, a vaccine, even though maybe it's not as effective as we had hoped, that there are other treatments. So, be vigilant. And
Right.
speaking of, diseases, not that the Mpox prevalence was a genuine outbreak, but there was news from Equatorial Guinea and Tanzania, that the Marburg virus disease had showed up there for the first time in Tanzania and was declared outbreaks in those places. Can you tell us a little bit about MVD and these outbreaks?
Yeah, so Marburg virus is hemorrhagic, most usually fatal viral hemorrhagic fever, very similar to Ebola. And it is very scary because the mortality rate is so high. It showed up in February in Equatorial Guinea, and then it kind of went down. And then it popped up in a couple other countries in Central and Eastern Africa. It's actually not like Ebola. Once you identify it and you isolate people and people use just the regular precautions, good isolation precautions with gloves and a mask and all that, the rates go down pretty easily if you just do those kind of simple steps. So the risk outside of those areas where they've reported it is low. And so like in the United States, very low. But, people could be coming back from those areas and show up with looking really sick. And, care is just really, supportive. And, but like with Ebola, the old reports were that it was up to 90% fatal, 40 to 90%, the numbers were all over the place. And then when you really looked at places that were taking care of the patients, it was much less than 40%. So like 10% or whatever. So anyway, but anyway, it's a nasty thing it could be fatal. So we have to be careful with it, but it's this is a problem that's being addressed globally now, still in those more remote places in Africa.
Well, thank you so much for your expertise and filling us in on these new headlines. It is greatly appreciated. And thank you all for joining us. We invite you to submit your COVID-19 infectious disease and public health questions via Facebook at NU Institute for Global Health or by email at globalhealthinstitute@northwestern.edu. Thank you again, Dr. Murphy. Your expertise is much appreciated.
Thank you, Katie, for organizing this meeting. Thank you.
Have a great day.